Hey, future nurses, if you're prepping for your boards or just gearing up for the labor and delivery floor, you are in the exact right place. Today's explainer is all about taking those super dense clinical criteria on labor and birth complications and turning them into a high-yield study guide that actually makes sense. We're going to break down the mechanics, the high-alert meds, and the literal life-saving nursing interventions you absolutely have to know.
Okay, let's just dive right into our escalation framework. 1. Interventions and procedures. 2. Dysfunctional and preterm labor. 3. Critical obstetric emergencies. And 4. An NCLEX knowledge check to wrap it all up.
All right, Section 1. Obstetric interventions and procedures.
So in a controlled clinical setting, our main goal is to actively assist providers, prevent complications, and obviously promote positive outcomes for both mom and baby. But before any labor induction even begins, we have to confirm two crucial things: fetal maturity and cervical readiness. And that's exactly what the Bishop score measures. It evaluates the physical softening, effacement, and dilation of the cervix. If you see a score above 6, that tells us the cervix is ripe, and we're looking at a predictive success for induction. But if that cervix isn't ripe, well, oxytocic drugs just aren't going to do the trick, and you'll need mechanical or pharmacological ripening methods first.
Now, once that cervix is ready to go, we'll often see interventions like an amniotomy or oxytocin administration. An amniotomy is just the artificial rupture of the amniotic sac. But here is the massive clinical takeaway for you. The primary risk here is umbilical cord prolapse. If that cord slips downward with the sudden gush of fluid, you are officially in an emergency. Because of that, confirming fetal presentation beforehand is absolutely essential. Then we've got oxytocin, or Pitocin. This is a high-alert medication, guys. As the nurse, your vital role is to continuously monitor uterine activity and the fetal heart rate every 15 minutes during active labor. You are literally the safeguard against overstimulation.
Sometimes, despite everyone's best efforts, a mother's pushing might need some mechanical assistance during this second stage of labor. There are two main options here: forceps, which are applied to the fetal head to pull along the pelvic curve, and vacuum extraction, which uses a cup placed over the posterior fontanelle for traction. For both of these methods, three things must be true. The cervix has to be fully dilated, the membranes must be ruptured, and the bladder has to be completely empty.
Moving right along to Section 2. Dysfunctional and preterm labor.
Moving away from those planned procedures, we sometimes run into abnormal labor progress, which clinically we call dystocia. You really need to mentally compartmentalize these two conditions for your exams. First, hypertonic labor dysfunction. This usually happens early on, in the latent phase, before 4 centimeters of dilation. The contractions are frequent, poorly coordinated, and super painful. But the absolute key feature to remember is that the uterine resting tone between contractions remains tense. That's bad news because it reduces placental blood flow. Hypotonic labor, on the other hand, is way more common. It happens later in the active phase, and it's basically when contractions just become too weak to be effective.
Now, if labor kicks off before 37 weeks, we're officially in preterm labor management. Predicting this often involves testing vaginal secretions for fetal fibronectin. If preterm labor is actively happening, the main goal is to stop the contractions, which is called tocolysis. Magnesium sulfate is our go-to here. But listen up, here's a massive safety alert. The FDA highlights that magnesium sulfate is also incredibly effective at protecting the premature fetus from developing cerebral palsy. It's a dual-purpose powerhouse. However, if preterm birth is just inevitable, we administer corticosteroids, like betamethasone, strictly to speed up fetal lung maturation.
All right, taking a deep breath. Section 3. Critical obstetric emergencies. We're shifting into those high-adrenaline, rapid-response scenarios where literally every second counts. Let's talk about a prolapsed cord emergency. This is where simple physics can save a life. What you're seeing is the knee-chest position. When the umbilical cord drops past the fetus and gets crushed against the pelvis, the oxygen supply is completely cut off. By getting the mother into this knee-chest position, gravity shifts the fetus right out of the pelvis, instantly relieving that pressure. Okay, picture this. You see a prolapsed cord. What do? Let's walk through the exact, immediate sequence of actions you must take the split second you identify it. Step 1. Use a gloved hand in the vagina to manually push the fetus upward and off the cord. And do not remove your hand. Seriously, you will probably be riding on the bed in that exact position all the way to the OR. Step 2. Get the mother into that knee-chest or Trendelenburg position. Step 3. Crank the oxygen. 8 to 10 liters per minute by face mask to maximize fetal oxygenation. And step 4,
Prepare your team for a prompt, rapid delivery, usually a cesarean. Two other absolutely terrifying emergencies you need on your radar are uterine rupture and amniotic fluid embolism. Uterine rupture is exactly what it sounds like, a tear in the uterine wall, and it often happens in women who have previous cesarean scars. Look out for sudden signs of hypovolemic shock, like a rising pulse and falling blood pressure, combined with a very distinct chest pain right between the scapula or shoulder blades. Then there's amniotic fluid embolism, which happens when fluid enters the mother's bloodstream. This causes immediate, massive respiratory distress and shock. Both of these situations require lightning-fast recognition and intensive surgical or life support interventions.
Okay, Section 4, NCLEX Knowledge Check. Let's see what's stuck.
All right, take a breath. We've covered some incredibly dense ground today. Let's see how well you can apply these facts with a quick quiz. Scenario 1. A nurse is caring for a patient receiving oxytocin. Which observation requires immediate report to the healthcare provider? Is it A, contractions every 4 minutes? B, fetal heart rate 140 BPM? C, contractions lasting 95 seconds? Or D, moderate variability? Go ahead and lock in your answer.
And the correct answer is C. This ties directly back to our earlier safety alert. Contractions lasting longer than 90 seconds, occurring more than every 2 minutes, or resting intervals shorter than 60 seconds, all of that indicates tachysystole, basically uterine overstimulation. If the uterus doesn't get a break to relax, the placenta can't refill with oxygenated blood, and that leads straight to fetal compromise. You've got to stop the oxytocin and page the provider immediately.
Let's keep the momentum going. Question 2. What is a primary indication for an amnio infusion during labor? Is it A, to induce labor? B, oligohydramnios causing umbilical cord compression? C, to ripen the cervix? Or D, to stop preterm contractions? The answer is B. Think back to that mechanical cushion concept. If a patient has oligohydramnios, meaning their amniotic fluid is super low, the umbilical cord doesn't have its normal protective fluid cushion and gets squished during contractions. By infusing sterile fluid directly into the uterus, we essentially replace that cushion and stabilize the baby's heart rate.
Question 3. Let's see if you remember that comparison table. Which of the following is a key characteristic of hypertonic labor dysfunction? A, occurs in the active phase. B, uterine resting tone is tense. C, contractions are weak. Or D, treated with oxytocin augmentation. The crucial point here is B. Hypertonic labor happens early on in the latent phase, and the main giveaway is that tense uterine resting tone right between those painful, uncoordinated contractions. Remember, hypotonic labor is the one with the weak contractions during the active phase. And please, whatever you do, never give oxytocin to a hypertonic uterus. It needs to rest, not be augmented. All right, question 4. Let's distinguish those preterm meds. A patient in preterm labor is prescribed magnesium sulfate. According to the FDA, what is a primary fetal benefit of this drug? A, cures chorioamnionitis. B, protects against cerebral palsy. Or C, speeds lung maturation.
The correct choice is B. Yes, magnesium sulfate is used as a tocolytic to stop contractions, but its massive benefit for the fetus is neuroprotection. It actively protects that premature brain from cerebral palsy. Do not mix this up with corticosteroids like betamethasone. Those are the ones we use to speed up lung maturation.
Okay, last one. Our final, highest stakes clinical scenario. What is the priority nursing action upon discovering a prolapsed umbilical cord? A, administer oxytocin. B, place mother in a knee-chest position. C, perform external version. Or D, ambulate the patient.
You guessed it, the answer is B. Getting the mother into that knee-chest position is the immediate physical intervention we looked at earlier. It uses gravity to pull the baby's head away from the pelvis, freeing up that trapped cord and getting oxygen flowing back to the baby instantly.
Honestly, you all did fantastic. Keep in mind, in the world of obstetrics, catching a slight deviation from normal, like a tense resting tone or a sudden dip in the heart rate, isn't just about passing your NCLEX. It's literally about saving 2 lives at exactly the same time. So the next time you step onto that labor floor, ask yourself, if that monitor suddenly drops, are your hands ready to react before your brain even has time to panic? Review these concepts, trust your training, and stay vigilant out there. Catch you in the next explainer.